Welcome to the 2017 Annual Breast Cancer Summit. My name is Kristen Thorne and I'm the Long Island correspondent for Channel 7 Eyewitness News. Very happy to be with you this morning. Thank you. Yes, I know, I have a long day ahead of me. It's elections tonight, so I'm going straight from here to work till midnight. So it's going to be a long one, but it's okay. Lots of coffee today. I'm so excited to be back as your MC for this morning's program. This will be my 5th year as a host of this event. My friend Shannon Saturno, some of you may know her, was diagnosed with triple-negative breast cancer in 2013 when she was just 29 years old and 28 weeks pregnant with her daughter. She was my photographer's daughter-in-law from Babylon. Despite chemotherapy treatments, Shannon continued work as a special education teacher in Babylon. She even starred in a video produced by First Company Pink as part of its Got Checked campaign. It's a really great video. I encourage you to check it out. It has about 45,000 views on YouTube. It was important to Shannon to educate women about the importance of getting checked and paying attention to your body. Unfortunately, Shannon lost her battle with breast cancer last summer. My commitment to this event is in Shannon's honor. She knew and strongly advocated that knowledge is power. You'll see if you look ahead at our agenda today, there is a focus on younger women and breast cancer, particularly with today's keynote speaker, Alan Rose, who at just 26 years old made headlines with her controversial decision to undergo a prophylactic mastectomy and reconstruction. Her story is one of empowerment, and Alan is a champion of preventative health care. Throughout the program today, we encourage you to ask questions. Hopefully the speakers and exhibitors will provide new information that may add to your understanding and perhaps even treatment of this disease. There are comment cards on the table. Janine, I don't know if you can hold one up. Is there any over there?
They're right in the center of the table.
They're in the center of the table. Oh yeah, there they are, over there. So there are the comment cards. If you have a question, all you have to do is hold one up and the volunteers will come over to collect the cards throughout the program. So feel free to jot down any questions that you may have today. To kick things off, we're going to first turn the mic over to Dr. Roger Simpson, President of Long Island Plastic Surgical Group, the founding organization of this event. Dr. Simpson.
Good morning, and thank you very much for attending. And, first, I'd like to start by thanking Kristen Thorne for her ongoing support of breast cancer education. Many of you don't know that Kristen was recently honored by the Long Island Plastic Surgical Group for her efforts in keeping the community informed and educated. And last spring, she was awarded Woman of the Year by Star Network's Kings of Long Island. Over the years, we've been continually impressed by your community endeavors and extremely grateful for the time that you contribute and donate to the Breast Cancer Education Initiative. So please join me in giving Kristen a round of applause. Thank you, Kristen. The Long Island Plastic Surgical Group is very proud to sponsor and produce this annual event. It's our sincere hope that you come away with resources and information to best guide your treatment and breast cancer experience, whether you're here as a survivor or a caregiver. Every year for the past 6 years, we've offered this educational event at no charge to the community. Our surgeons work with many breast cancer survivors, and we are acutely aware of the need for greater access to information and support in this population. We realize that there is a wealth of information online, but by being here today, patients, survivors, and family members can obtain both authoritative information and human interaction with the experts that you will meet later on today. And as always, education is our primary goal. Each year I open this event with the history of how this forum came to be, and I still believe that it's a very important reminder of how far we have come. Breast cancer is the most common cancer among women in New York State. On August 15, 2010, then Governor Patterson signed into law an amendment to New York's public health law concerning the availability of information and access to breast reconstruction surgery for patients diagnosed with breast cancer. The amendment required that doctors and hospitals in New York discuss information regarding breast reconstruction with patients undergoing mastectomy, lymph node dissections, or lumpectomy. This was a tremendous step forward in breast cancer education, And as many women were having surgeries to remove their cancer, completely unaware of what their reconstructive options were. My colleagues and I have found it imperative to respond to legislative revision in a way that would prompt further reconstructive education and, of course, awareness for all of you. With this information in mind, the first annual Breast Cancer Summit was born in 2011. Changes in the legislation on breast cancer and breast cancer education have continued since 2011. Earlier this year, Governor Andrew Cuomo announced that health insurers are now required under New York insurance law to provide medically necessary coverage for 3D mammography without copays, coinsurance, or deductibles. 3D mammography screening, or tomosynthesis, can be more effective at detecting cancer in dense breast tissue. This announcement builds on the legislation that he signed just last year to enhance access to breast cancer screening for all, and by requiring 210 New York hospitals and clinics to extend hours of service and screening outside the standard 9 to 5 business hours. And also eliminating deductibles and co-payments for this type of screening mammographies. It is our goal to open the conversation and to empower women with the knowledge needed to make the best choices for their care. As we all know, the best protection against breast cancer is early detection and diagnosis. The American Cancer Society estimates that about 250,000 new cases of invasive breast cancer and 65,000 cases of in situ carcinoma will be diagnosed in 2017, underlying the importance of this education. While breast cancer is unusually common in women before the age of 40, the number of young women diagnosed with advanced breast cancer, like Kristen's friend Shannon, is unfortunately on the rise. According to a study published in the Journal of the American Medical Association in February 2013, in the past 30 years, more women between the ages of 25 and 39 were diagnosed with metastatic breast cancer, going from 1.5 cases per 100,000 women to about 2.9 cases. That's a doubling of the rate in 30 years. This means that 800 women younger than 40 are now diagnosed with metastatic breast cancer each year, compared to about 250 women in 1976. This increase, although it looks relatively small, is extremely troubling. Breast cancer in younger women tends to be more aggressive and harder to treat. Also, routine screening isn't typically recommended for women under 40 years of age. This is why self-examination and annual breast examinations are so terribly important. While we make it a point every year to create a program that includes updates on advanced medical practices, procedures, and technologies on the subject of breast cancer, much of today's program is especially relevant to younger women. Today, we will explore a new treatment using the body's immune system to fight cancer. We'll discuss breakthrough technology in cancer detection in dense breast tissue. And our speakers will be sharing messages of hope and resources for support, including fertility options, which is a brand new topic for this forum. And finally, we'll have an expert panel on innovations in breast reconstruction by multiple surgeons. Our keynote speaker this morning, Ms. Allen Rose, was motivated to explore her family history and take charge of her health care. We look forward to hearing Allen's inspiring story a bit later in the program. And now at this time, it's my pleasure to introduce our first speaker, Dr. Jules Cohen. Dr. Cohen is an associate professor of medicine at Stony Brook Medicine. Dr. Cohen is a medical oncologist who specializes in the clinical care of women with breast cancer. He received his medical training at Cornell University, trained in hematology and medical oncology at the Cornell campus of New York Presbyterian Hospital. Trained in laboratory research at the famed Rockefeller University in New York. And Dr. Cohen will be speaking on the topic of immunotherapy, which is emerging as a promising form of breast cancer treatment. Dr. Cohen.
Good morning, how are you? My name is Jules Cohen, and as he said, I'm a medical oncologist at Stony Brook, and I specialize in breast cancer. I would say 90-95% of my patients are women with breast cancer and 2 men with breast cancer. And I'm going to talk today about immunotherapy for breast cancer. So you've probably heard a lot in the media of different immune therapies, immune strategies to treat different kinds of cancer. And it's a very big topic, and it has a lot of relevance in a lot of different types of malignancies, including breast cancer. In some ways, we have better immune therapies or more effective immune therapies in some other cancers as well. So this talk will be a little bit general, and we'll touch on some specific issues regarding breast cancer and breast cancer immunotherapy, and just sort of demystify the immune system for you. So why immune therapy? Why do you want to harness the immune system to treat cancer? Well, traditional cancer therapies, as shown here, are indiscriminate. So cytotoxic chemotherapy, right, kills cancerous cells, but it kills healthy cells as well. And of course, that's the problem and what's responsible for the long-term and short-term side effects of traditional chemotherapy. In particular, cancer chemotherapies target rapidly dividing cells. And so tumors, by definition, are rapidly dividing, and that's why chemotherapies can be effective against tumors. But the side effects of the chemotherapy tends to target other cells that are rapidly dividing. So the hair follicles are rapidly dividing. That's why chemotherapy, many types of chemotherapy, although not all, make you lose your hair. The GI tract, the surface of the GI tract is rapidly dividing. That's why people have a lot of GI toxicity. And the bone marrow is composed of rapidly dividing cells, and that's why people have problems with their blood counts, their red blood cell count, their white blood cell count, and so on with chemotherapy. So wouldn't it be nice if we had treatments that selectively killed cancer cells and left all the regular cells alone? And this is where immunotherapies come in. That if we could somehow figure out how to use the immune system to target these cancer cells, but with no collateral damage, that would be ideal. So when people started to understand the immune system, and started to think about using the immune system not only to treat infectious disease but to treat malignancy, people were very excited, and there was a whole slew of early studies, early attempts to use the immune system to treat cancer. Unfortunately, most of these early attempts were unsuccessful. And so what went from early enthusiasm when changed to a general feeling of skepticism about immune therapy. And so when I was completing my training not that long ago, and I said, well, I wanted to work in immune therapy, people laughed at me, because basically they said, well, it's been around for 30 years, it doesn't work, move on. We're studying what are called targeted treatments. There are all sorts of new types of drugs, and people at that point felt that immune therapy was not very promising. However, in recent years, we've had a slew of treatments come to the clinic and become approved by the FDA, and now people are enthusiastic again, and there is a renaissance of immune therapy in the treatment of cancer. So what does the immune system do? It is essentially, it fights infection, right? Without an immune system, we would be very susceptible to all the various microorganisms that are ubiquitous in the environment, viruses, bacteria, fungi, and so on. And so this obviously is a very important part of living, essentially. And of course, people who have severe immune deficiencies, such as in the HIV and AIDS crisis and so on, were plagued with a lot of infections that they couldn't control. However, what's also interesting about the immune system is it provides surveillance for cancer cells. The term is tumor immunosurveillance, and essentially it's probably the case that the body is constantly making little incipient cancers, maybe a single cell or 2 or 3 cells or 10 cells. And the immune system has the capacity to identify these cells, to recognize them, and to wipe them out before they become clinically apparent and before they become a problem for you. So, and we know this from many, there are many lines of investigation that kind of demonstrate that this is the case. One of the things that we know is when patients are immunosuppressed, whether it's from a disease such as HIV or whether it's from drugs such as the immunosuppressive drugs that we use in organ transplant, we know that they have an increased risk of not only infection but malignancy. So one of the most important features of the immune system is it must distinguish, quote unquote, self from non-self. Self is the host, your normal healthy tissues, and non-self would be something that essentially is invading the body and does not belong there. And again, all those microorganisms that we spoke of, viruses, bacteria, fungi, protozoa, you name it, these are non-self, and it's very good that the immune system is able to identify them, attack them, kill them, wipe them out, and treat or prevent any clinically apparent disease. Cancer cells also should be recognized as non-self, and so that, again, the immune system can identify them, target them, and wipe them out. If the immune system attacks self, this is what we call autoimmune disease, or allergy, which is a form of autoimmune disease. And you've probably heard of a lot of these. Some people, it's very common to have autoimmune thyroid disease, which is relatively easily treatable. And then there are more difficult autoimmune diseases, lupus, myasthenia gravis, it goes on and on. And so we don't want the immune system to become dysregulated and target the host cells, because again, that can cause disease that is every bit as difficult and problematic as malignancy, for instance. One of the problems is that cancer cells pretend to be self, okay? They essentially are derived from the host, right? Your breast cancer, unfortunately, comes from your own breast cells that have become dysregulated, deranged, and so on. And sometimes, or these cancers really purposely, in order to survive, they come up with ways of hiding themselves in plain sight and avoiding recognition by the immune system. And if the immune system kind of walks on by and bypasses them, those cells then are free to grow into a tumor that can actually cause clinical problems for the patient. So the idea of immune therapy involves educating the immune system. How do we instruct the immune system to differentiate between self and non-self, and how do we tell it to identify cancer cells and to rev themselves up against the cancer cells, but again, to leave the normal tissue alone? So broadly speaking, there are two kinds of immunotherapy. There's the so-called passive immunotherapy and active immunotherapy. Passive immunotherapy is essentially like giving a man a fish. You feed, or a woman a fish. You feed them for a day, and but then it disappears, and they'll have to find another fish the following day. Active immunotherapy, which is unfortunately more difficult to achieve, is like teaching somebody to fish, and that once they have those skills, they can provide for themselves indefinitely. So we would like to be able to educate the immune system so that it can always rise against a threat of cancer cells. But unfortunately, most of our techniques so far involve giving the patient, a fish, and that we sometimes have to give them fishes every day in order to keep their cancer under control. So more specifically, so-called passive immunotherapy has to do with quote-unquote ready-made antibodies inoculated from the outside. So this is sort of in the vein of intravenous immunoglobulin, which you may have heard of, where people used to raise immunoglobulin in horses, and then they would extract the immunoglobulin for the horses and then use that to treat various infectious diseases. But essentially, it's immunoglobulin or antibodies from the outside that we put into the patient to serve whatever purpose we needed to serve in terms of killing cancer cells. Active immunotherapy is more like a vaccine, such as the smallpox vaccine, where you take pieces of the organism or the cancer and you infuse them into the patient with some kind of immune stimulant, and that causes the body to make an immune response against that microorganism or that cancer cell, and that then the body develops immunological memory, and that any time the body is challenged by that, again, microorganism or cancer cell, it can then activate itself, destroy the invader, and again, with a minimum of toxicity to the patient. So one example of how active immune therapy is more difficult to achieve than passive immune therapy is that there is only one FDA-approved cancer vaccine that has been developed so far, and this is so-called Provenge. I can't pronounce the generic name, Sipuleucel T, and essentially this is used in prostate cancer and in advanced prostate cancer, and this has been shown to prolong survival in men with advanced prostate cancer, and it involves taking out a patient's white blood cells, stimulating them in the lab with little pieces of prostate cancer, essentially, and immune stimulants, and then reinfusing those white blood cells into the patient, and essentially then the immune system has become educated to kill cancer cells. But again, this is a very difficult technique, and it's sort of in its infancy, and we do not yet have this type of cancer vaccine in breast cancer, not to mention colon cancer, lung cancer, and so on. It only exists in prostate cancer so far, at least as far as that is available on the market. So what's easier, again, is to make these monoclonal antibodies, which is the so-called passive immunotherapy. And essentially an antibody, right, is a Y-shaped molecule that's made by the immune system, essentially to fight microorganisms, and that science has been able to appropriate this tool to use to target various molecules in the body to fight cancer. So the tail of the Y-shaped molecule, which you see on its side there, binds the white blood cells, and that's how the white blood cells know where to go. And the sort of the fork of the Y-shaped molecule binds the microorganism or the cancer cell or whatever target that you pick, and essentially brings the white cells to this target and allows the target to be destroyed by the white blood cells. One of the benefits of using antibodies to fight cancer is that they're extremely accurate. So they hit your target and they leave everything else alone, by and large. And this again allows for very specific killing of tumor cells, but with a minimal of collateral damage to the cells, the healthy cells around it. There are two basic ways in which we can use these antibodies. We have unarmed antibodies and armed antibodies. Unarmed, essentially, is just a naked antibody. They can coat the cancer cell, and when the cancer cell is coated with antibodies, it attracts white blood cells to come and kill that cancer cell and eat them up, such as in that picture there. An armed antibody would be an antibody that is actually loaded with either a chemotherapy molecule or a radioisotope, and it will deliver that sort of toxic payload directly to the cancer cell to destroy it. And it'll allow us to use lower doses of chemotherapy or radiation to treat the cancer cell, so that again, we have very specific killing of the tumor cell with a minimum of toxicity to the healthy cells. And some examples of so-called unarmed antibodies are Herceptin, which I'm sure a lot of people are familiar with, which we use in breast cancer, and it was a huge advance, and it's been around for a while now, and that targets the protein HER2, which is overexpressed on approximately 20% of breast cancer, so it's very useful in the patients who have HER2 positive breast cancer. Unfortunately, we don't have anything similar for the HER2 negative breast cancers, which comprise the majority of breast cancers so far. And then we have another antibody called Rituxan that's targeted at a protein called CD20 that's expressed on lymphoma and has increased our cure rate for many patients with lymphoma. The armed antibodies can be seen as sort of a molecular guided missile, where again you have very exquisite, specific targeting of the cancer cell with a minimal of collateral damage to the tissues around it. And these are two drugs that are FDA approved and available. Kadcyla is for HER2 positive breast cancer. It essentially is the Herceptin molecule, but it's loaded with chemotherapy, so it delivers that chemotherapy directly to the cancer cell to kill it. But if that chemotherapy were used in a higher systemic dose without Herceptin, it would be too toxic to tolerate. So again, we can use relatively small doses of chemotherapy, but with precision targeting and achieve our goal, again, of killing the cancer cells and leaving the healthy cells alone. And then this drug Zevalin is a drug that's used in lymphoma, and it's essentially the Rituxan antibody. attached to a radioisotope, and it delivers that radioisotope directly to the lymphoma cells, again with minimal collateral damage as far as the healthy cells go. So another way in which we can use these antibodies, specifically the unarmed antibodies, is we can target the immune cells themselves. And wouldn't it be nice if we could use the antibodies to either turn up or in some cases turn down the function of immune cells? And specifically the type of cells that we're interested in targeting are the T cells. Okay, the T cells are fundamental in the immune system, both for the treatment of infection or the prevention of infection and the response against infection, and also the response against malignancy. And there are basically two varieties of T cells, or the so-called helper T cells and the killer T cells. The helper T cells is not exactly what we're going to go into here, but just to let you know, the helper T cells are the cells that are attacked by the HIV virus. And without these helper T cells, much of the immune system can't function. And that's why HIV and AIDS are such a devastating disease, fortunately controlled in many people these days with medicines, but it's devastating because without those helper T cells, your immune system falls apart and patients are susceptible to a wide range of opportunistic infection and malignancy. The killer T cells are more of what we're going to talk about today. The killer T cells, essentially, they can kill cells that are infected with virus, and they can kill cancer cells. And wouldn't it be great if we could turn up the function of these killer T cells to wipe out those cancer cells? And again, to wipe them out relatively specifically so that the killer T cells don't cause other problems in the body. So how do we turn up T cell function, right? We need to turn it up to 11 because cancer is a difficult problem to solve. And so there are two basic ways, conceptually you could think of to turn them up. You can either jam on the accelerator pedal and make those T cells go faster, or you could take off the brakes. If the brakes don't work, those T cells are going to accelerate and kill that cancer cell. And it turns out at the moment what the strategies all involve taking off the brakes. That seems to be easier to achieve than to stimulate the T cells directly by jamming on the accelerator. And so why is this the case? Well, tumors have the ability to inactivate T cells. So we said earlier on that this phenomenon of tumor immunosurveillance was very important. It's how the body prevents the development of cancer when the cancer is tiny, when it's 1 cell, 2 cells, 10 cells. But tumors become smart. And unfortunately, the older you are, not only the smarter the tumors, but the less robust the immune system is, and the more likely it is that a tumor cell will break through this tumor immunosurveillance. And again, there are many mechanisms by which tumors achieve this, and one specifically is deactivating or inactivating the T cells. So basically, the tumor will find a way to bind to the T cell and will attach itself to a receptor on the T cell that tells the T cell to turn itself off. And so a variety of drugs have now been developed to interrupt that interaction. And so by interfering with the tumor cells inactivating of the T cell function goes up and can kill the tumor cell. So essentially, right, this is a double negative, right? The tumor puts the brakes on the T cell, and the drugs that we use release the brakes and allow the T cells to function normally. And these drugs, they have a lot of different sort of names. The sort of common name for them these days are called checkpoint inhibitors, right? Because these checkpoints on T cells are what restrain them for becoming overly active and causing autoimmune disease. But in the case of cancer, you want to inhibit these checkpoints so the T cells become more active and kill the cancer cells. And without getting into too many of the nitty-gritty details, these are two of the drugs that are FDA approved. Unfortunately, they've not yet been demonstrated to be helpful in breast cancer, although we have some hope that at least in the triple negative variety of breast cancer they'll be useful, but they've been shown to be useful in multiple diseases such as melanoma, kidney cancer, lung cancer, bladder cancer, and on and on and on. So it's just a matter of figuring out which type of breast cancer may be the most susceptible to treatment with these kinds of drugs, and how to use these drugs in such a way that it makes that it allows us to kill breast cancer cells. And these two drugs are Opdivo and Keytruda. Opdivo, I believe, is advertised a lot on TV. So, however, it is a delicate balance, right? Because by taking off the brakes with the checkpoint inhibitor, we can produce a response in the tumor and we can shrink the tumor. However, if we overdo it, right, turning up that volume to 11, we can induce autoimmune disease. And so, unfortunately, so far, no free lunch, that there's always some price to be paid. And the downside of using these checkpoint inhibitors and facilitating the immune destruction of cancer cells is that we provoke autoimmune disease. So finally, I just wanted to get into sort of the latest and greatest technology that's been developed. Again, unfortunately, we don't have it yet in breast cancer, but we will someday, or have some variety of treatment like this for breast cancer, maybe HER2-positive breast cancer to start with. But essentially, this takes the best of both worlds. It's called the chimeric antigen receptor T cell, or the CAR T cell, which again you may have heard about on the news. These drugs, there are two now, I believe, that are FDA approved, one for relapsed childhood leukemia, and the other one for relapsed adult lymphoma. And essentially, a chimera is a beast that's made up of two different beasts. You know, I don't believe it's a lion and an eagle. I think that's a griffin. I have to look up what the chimera is classically, but in any case, that is the basic idea. And this is essentially a molecule that has been engineered in the lab to combine the best of the killer T cell and its ability to destroy cancer cells, and the exquisite specificity of the antibody molecule. So this is sort of the structure of this molecule. Basically, the tip of it, which is in green here, is essentially the antibody part, and it's like the bow and arrow. It's going to hit that target right in the center and not miss the target at all. The blue and purple regions are the so-called co-stimulatory molecules. We didn't really talk about those today, but those essentially are like pressing on the gas pedal and kind of accelerating and revving up the immune response. And the little red tip is a signaling molecule. It's like the transmission of a car, and it converts the internal combustion engine into the wheels moving. And you make these more or less, at least loosely, like you make the Provenge vaccine for prostate cancer. You have to treat the patient with chemotherapy, obliterate 90% of the leukemia that's there. You have to take out the remaining white blood cells, and you have to insert this bioengineered molecule into those T cells using a virus, actually. And then when these T cells now have this complicated bioengineered molecule, they can be reinfused into the patient, and then they home very, very specifically to those cancer cells and then destroy them using the power of the killer T cell. And again, this is prolonged survival in children with relapsed leukemia and in adults with relapsed lymphoma. And this is just some of their data that led to FDA approval, just showing that essentially, leukemia in children was the first disease to be cured by chemotherapy alone. Most children with, ALL or acute lymphocytic leukemia are cured with conventional chemotherapy, although it's very complicated as far as a regimen, and it takes years, and there are many probably long-term side effects as far as development and so on. But there is a small percentage of these children who are not cured by conventional chemotherapy, and generally they do very, very poorly and either need a bone marrow transplant, or unfortunately a lot of them die of their disease. And this is a huge advance in terms of treating these children. The problem is the drugs are very expensive, because partly there was a lot of R&D that went into developing the drugs, partly the creating the drug specifically for each individual patient, because it has to do with taking those white cells out and putting them back in again and so on, is cumbersome and costly, and partly the drug companies have to keep themselves afloat. In any case, this is for a single dose, which is the dose for childhood leukemia, but for this one dose of drug, it's $475,000. And the question is, how are we as a society going to afford price tags like this? So, in conclusion, immune therapy is targeted towards tumor cells with a minimum damage to healthy cells. Unfortunately, active immunotherapy or cancer vaccine development is more or less in its infancy, and we need a lot more work in that direction. We do use a lot of passive immunotherapy, so-called monoclonal antibodies, where we can target the tumor cells for destruction. With the unarmed antibodies, we can deliver toxic payloads in the case of the armed antibodies, or we can just turn up the activity of the T-cell function. And then finally, the latest and greatest is the chimeric antigen receptor, or CAR T-cell, and it's sort of like having a super antibody that is combined with the super T-cell, and that can destroy tumors very effectively. And so although there was a period of time where no one believed in immune therapy, it has now sort of come into its own, and hopefully we'll see it in breast cancer more and more. So thank you for your attention. Sure. So I believe we have a little time for questions. If anyone has anything they want to ask, either about immune therapy or breast cancer or whatever else you can think of. Yes, please.
Good morning, and thank you for taking questions. We are, as a survivor and also as an advocate, with respect to the current standard of care for triple negative. You mentioned that immunotherapy might be something in the horizon, but what is the current standard of care for triple negative?
Well, it's a broad question because, there are many things that go into our treatment decisions, in terms of the stage of the disease and so on. Basically, broadly, very broadly speaking, for early stage triple negative disease, which is stage 1, 2, or 3, which we consider curable, most of the time the treatment would be surgery, either lumpectomy and mastectomy, chemotherapy, and probably, or in many cases, radiation, and not necessarily in that order. So that we've started to use preoperative or quote-unquote neoadjuvant chemotherapy more and more in triple negative patients because it's effective and because it can downstage the disease so that women who ordinarily may have needed a mastectomy and a full lymph node dissection and would be at high risk for things like lymphedema, we can convert some of those women at least to lumpectomies and sentinel lymph node biopsy so that they have much less in the way of long-term morbidity or side effects from the treatment.
Tangential, and the chemotherapy that's currently seen as effective as in standard of care?
I mean, unless the disease is particularly small.
No, stage 1, 2, 3.
Right, but I mean, there are exceptions, on the low end and the high end, but essentially, I would say most people still use what's called, dose-dense ACT, which is adriamycin cytoxan, and then Taxol, sometimes with carboplatin.
Thank you so much.
Sure.
Thank you. I do a lot of research and reading on the internet, and just your opinion, the United States does a lot with immunotherapy and trying to figure it out, but other countries that have socialized medicine are not so much immunotherapy, but doing other things to find drugs within nature that can cure cancer. Like Australia has a company called Cubotics that has something called EBC46, which is found in nature that cures cancer. Cuba does something called EGFR, which is natural and stimulates your immune system to fight the cancer. It's mind-boggling. I want your opinion on it because the FDA won't approve anything that's found in nature. The United States won't go that route. We're doing immunotherapy, which costs $475,000. my insurance company isn't going to pay for it. Why can't the United States look for things found in nature that cures cancer, which we know that there are?
Well, another complicated and broad question, I think, there may be a certain misconception about what is found in nature and what is not found in nature and what is going on in the US as far as research versus, say, Western Europe or Australia. A lot of the conventional Western drugs are found in nature. They're not really all completely designed and engineered and fabricated in the lab. So a lot of our conventional cancer chemotherapies come from, funguses and other microorganisms, sea sponges and so on. So Taxol, paclitaxel, right, which was a huge breakthrough in breast cancer treatment, is found on the bark of the Pacific yew tree in the Pacific Northwest. So that was a natural product that was studied very carefully in ovarian cancer, breast cancer, many types of disease, and became a standard of care. That was produced apparently by a fungus on the bark of the Pacific yew tree. A lot of the newer breast cancer medicines also, there's a drug called eribulin, there's a drug called exabebolone, and so on. They also, I believe, are originally derived from natural products. So the organized pharmaceutical industry, which is multinational, a lot of these companies, have maybe a strong presence in the U.S., but they may be based out of Belgium, for instance. They don't care where the drug comes from. They just want it to work. And they want it to be tolerated, tolerable, and they want to be able to prove to regulatory agencies like FDA that the drug is safe enough and effective enough to be sold. And so whether it's from the lab or whether it's from the rainforest, as long as it works. And science is nature, right? All this stuff is nature, whether it's scientists in lab coats who are working on it, or whether it's growing in the ground. This is all manipulating and understanding nature to use it for the benefit of humankind. So. Yes.
Hi. Are you aware of any current research on any potential vaccines for breast cancer? I know I heard some time ago that the National Breast Cancer Coalition was working on the Artemis project, which had to do with that. Do you know anything about that?
I don't know anything specific about that project. Certainly there are many trials in progress trying to develop breast cancer vaccines. Certainly HER2 is a very, very important target, and there are many different efforts to try to develop a vaccine against HER2 targeted or HER2 positive breast cancer. The vaccines, you can think of them in two ways. You can think of them again, this is the basic framework for breast cancer and most solid tumors, is that we have the early stage disease, stages 1, 2, and 3, which are curable, and we have late stage disease, which is stage 4, which is not curable. So the goal of treating stage 1, 2, 3 disease is to cure the patient of their breast cancer, say. And the use of a vaccine in that setting would probably be after all the conventional treatment, surgery, radiation, maybe chemo, hormonal therapy, Herceptin, whatever, that then you would give the patient the vaccine to reduce their risk of relapse. In the metastatic or stage 4 setting, the patient is by definition not curable, with very few exceptions, and the use of a vaccine in that setting would be to shrink the disease, to control the disease, to keep people alive longer, and to maintain their quality of life. So yes, there are, I'm sure, a lot of vaccine trials going on in breast cancer, but nothing that's that's been demonstrated conclusively to work. So, thank you very much.
Thank you, Dr. Cohen. If you didn't get your question answered and you still have it, you can just write it on the comment card and leave it face up on your table with the writing, and the volunteers will collect them and make sure that the question gets answered for you at some point during the program. We can make sure you meet with people and get your questions answered. I also want to invite anyone who's sitting in the back or can't see the screens. We've got some open tables up here, so feel free to move. Don't feel like you have to be stuck in your table. If you really can't see the screen, we'd love to have you come up to the front. We would now like to turn the stage over to our next speaker, Dr. Cornelia Ha, the Director of Radiology at Mercy Medical Center. Dr. Ha has studied medicine and completed her radiology residency at SUNY's Health Science Center at Brooklyn. She completed her fellowship in neuroradiology and musculoskeletal radiology at Long Island Jewish Medical Center. Dr. Ha is a licensed New York State radiologist. She is board certified by the American Board of Radiology, where she holds both a maintenance certification and a certificate of added qualifications in neuroradiology. Additionally, she is certified by MQSA, Mammography Quality Standards Act, and the American College of Radiology. Dr. Ha.
Thank you so much for having me today. I want to talk to you a little bit about molecular breast imaging. This is a relatively new technology, and at Mercy Medical Center, we're really proud that we are the early adopters of this technology. Currently, we are the only site in New York State that has this molecular breast imaging. So, just want to let you all know about this, and let's start. So just a little few statistics about breast cancer. So this year, we will see approximately 250,000 cases of new cancer diagnosed in women. Some of the statistics also say that 1 out of 8 women, by the time they're 80 years old, will develop breast cancer. The other interesting thing is, we always hear about what are your risk factors for developing breast cancer. Are you BRCA positive? What's your family history? And those things are all really important, but the fact is that 85% of the newly diagnosed cases of breast cancer actually are new cases. These women have no history of breast cancer. But the good news is, well, as of 1989, there's been a gradual decrease in the number of cases of breast cancer, and that's the mortality rate actually. So we're talking about people who are actually dying from breast cancer. There are less and less people, and that really is, in fact, due to early detection and better treatments. I'm on this little thing over here on the corner, the purple. This is very important. The one thing that really helps in terms of improving the mortality for breast cancer is education, and that's really why we're all here today. We want you to know what you need to do, what are the facts, and what can you do to keep yourself healthy. With breast cancer education and screening, we can save approximately, and this is an astounding number if you think about it, 37 lives every day in the United States. Let me ask you, how many women out there have dense breasts? Raise your hands. So breast density is something that's been in the news. And why is it important? Well, it turns out that about 50% of women have dense breasts. So, you can see from the little chart that your breast can be what's called heterogeneously dense or extremely dense, or you can be more on the fatty side. What does this mean? So our breasts are made up of predominantly fatty tissue and what's known as fibroglandular tissue. So there are elements that are fat and then the elements that are going to produce the milk. This is important because I'm going to show you a picture next, and you can kind of get an idea. Because we all hear this, and a lot of women think that they have dense breasts, and they actually don't, or they think they have fatty breasts, and they have dense breasts. You can't really tell if a breast is fatty or dense just by feeling what the breast feels like. It really is. You have to see what it looks like. All right, so this is a mammogram, and these are what breasts look like. So breast A is a fatty breast, and if you notice, breast A it's kind of dark, right? Look at breast C. Breast C is white. It's so what, right? Let me show you another picture. This is a breast implant. Look how white this is. All right, so the breast implant is the big round balls that are within the breast. Now, why is this important? It turns out that breast cancer on a mammogram is also white. This is breast cancer in a fatty breast. Can everybody figure out where the breast cancer is? Yeah. So if you have fatty breasts, it's great. Radiologists love you. You have fatty breasts, you come in, we're like, okay, everything looks good, we'll see you next year. But then, what if you have dense breasts? This is a dense breast. All right, there's breast cancer in here. Do you see where the breast cancer is? It's in here. It's really difficult. So what do we do in a situation like this, right? Well, there are several things. So obviously this breast, if you came in like this, we have no idea what's going on. There's calcifications here, there's all this white density there, and something's in here, but we may say, well, we're not really sure what's going on. You may be told, oh, we need some compression used, or we're going to send you for a sonogram. This is where molecular breast imaging comes in. So the things that we are looking at, mammogram, ultrasound, these are all anatomic ways of imaging the breast. Right? We're based on the anatomy of the tissue, the density of the tissue. Molecular breast imaging is a little different because it doesn't matter how dense the breast tissue is. All right? What is it? It's a nuclear medicine examination, and what does that mean? I'm sure you've all heard of having a stress test where they'll inject you with a small dose of radioactive material, and then you're under a camera, and they wait and they image the area of interest to see what areas are taking up the radioactive material. Well, that's basically the principle behind the molecular breast imaging. So what happens is you would come in, you get a small dose of a radio tracer, you're placed under a camera, and the reason this camera is actually different than other cameras, it's a gamma camera. I'm sure you've all heard of PET. PET is what's called positron, positive, right, there you go, right. So we're not measuring positrons, we're measuring gamma, and it's like, who cares, right? But it's really interesting because they actually made a new detector. So we were always looking at gamma, but the new detectors are tiny little multiple cameras, tiny multiple cameras that are put into these detectors. The detectors are positioned, there's two detectors, so one on top and one on the bottom, and they're positioned just like you would be positioned for a mammogram. So we mimic the positioning of the mammogram, and the reason that's really important is now we can look at the molecular breast imaging, and we can look at the mammogram, and we can correlate so that we can target things, and we can triangulate to see where areas of abnormality are. And remember, this is functional imaging as opposed to anatomic imaging. An example I can give you that I've given in the past, and people seem to like it, so I will tell you here again. Imagine if you had to look for something, let's say a rabbit or something, in a snowstorm, okay, a white rabbit. The rabbit is very white, the snowstorm is very white. It's really hard to see that rabbit based on what the shape of the rabbit is, based on what the anatomy of the rabbit is. But if you had something that would detect heat from the body of the rabbit, you could actually potentially take that and kind of scan an area, and you would be able to see where that heat was coming from. So that's really kind of like how molecular breast imaging works. It doesn't matter that you're in a snowstorm, you're going to be able to find the thing that's emitting the heat, which is the gamma rays, right? What do we use it for? So as I showed you, if you have dense breasts, it's great for people with dense breasts because it's a supplemental thing. If you have somebody who's got dense breasts, tons of calcification, tons of cysts, tons of nodules, and I'm sure, like, there are women out there who will say every time they go, they're doing a million things on me every year I go for a mammogram. Well, molecular breast imaging is great for problem solving because we can do this test, and if we see something that's abnormal on the MBI, we will go back and look at the mammogram and look to see, is there anything here potentially that needs to be biopsied? And if there is, then we will biopsy that area. We've had this machine now since April, and we've had 3 to 4 cases where these women were coming back multiple years, and many biopsies, all negative. We did the MBI, they had areas that were positive, and we biopsied just in the general area, any kind of calcification we could find, and they've come back positive. We had a woman who, actually she came in with a palpable mass on one side, and that was an obvious cancer, biopsied it. But before we took her to the OR, we did the MBI, and unbelievably, she had a cancer on the other side that really was mammographically and nearly sonographically occult. So what happened with her is we looked at the mammogram, there was absolutely nothing there on the mammogram. Took her to ultrasound, and there was a tiny, not even a mass, it was like a shadow, a little distortion in the way that the sonogram looks. We biopsied that, and that was an invasive carcinoma as well. So this is a great tool for problem solving. How does it work? What happens if you were to have the MBR? So this is a little overview on what would happen. Patient comes in, they get a dose of the cestamide. And if you're wondering, like, oh my God, they're injecting me with radiation, how bad is this? The dose is actually 8 millicuries. The effective dose of the body is about 2 millisieverts. You're like looking at me all like, what is she talking about? 2 millisieverts is about the equivalent of the background radiation for 1 year living on Long Island. So it's really a low dose. When you look at the relative scheme of like all the radiologic studies that you can have done, it's really at the lower end. It's slightly higher than a chest x-ray. It's about the equivalent of getting a mammotoma, 3D mammogram. So you have the injection, and immediately after you have the injection, you're able to be placed in the machine, and we can start the imaging. The imaging, as I said, mimics the positioning of the mammogram. So it's called a CC, craniocaudate, where the breast is pressed from the top to the bottom. And that image takes about 7 minutes to acquire, so 7 minutes on the right, 7 minutes on the left. Then we switch to the MLO, which is the medial lateral oblique, and that's the one where they compress your breast in an oblique plane. And again, 7 minutes on the right, 7 minutes on the left. A lot of women like this study because it turns out that when you have a standard mammogram, there's about 20 to 30 pounds of pressure that's placed on your breast, and anybody who's had a mammogram knows that it's really, it's not the best, right? With the MBI, it's about 11 pounds of pressure, so it's really light compression, and the compression, the reason that we compress is so that the breast stays in place. It's really to hold the breast in place so that it's not moving around. As soon as that's done, the images are generated immediately. We can look at the images, and it's basically, we can tell right away, is there something that looks hot or is there something that doesn't look hot? So it's a lot easier to see if, there's something that's going on. There are some cases where it could be more vague, and then we go back to the mammogram and the ultrasound, and we can work that out too, but it's a little simpler. So here, this is what the machine looks like, and this is a woman, she's being compressed in the CC projection, as you can see. Just a few little facts here. One of the things that's really amazing about MBI is that if you happen to have a negative molecular breast imaging, so if you have the molecular breast imaging and there's nothing on it, it's completely negative, there's a 99.7% chance that you do not have breast cancer. So just as much as you want to know if you have it, just the relief that you can have of knowing that you don't have it, I think that's just as important. So how would the MBI work? Well, every year from the time that you're 40, you go for a screening mammogram. The earliest that we will actually do a screening mammogram is 25, and that's for women who have first-degree relatives who have breast cancer at the age of 35. The recommendation is that you screen 10 years prior to. We don't like to go below 25, and this is a recommendation from the American College of Radiology. So when you have your mammogram, and we look at the images, the first thing we want to determine is this a fatty breast or is this a dense breast, right? If you have a dense breast, we look to see what your lifetime risk is. Now, all women out there who've gone for mammograms, you know, they make you fill out that little sheet of paper that everybody hates, and they say, you ask me these questions every year, what's going on with this? That actually is a breast cancer risk assessment questionnaire. We changed the title on that. Before it just said breast health. Ours now says breast cancer risk assessment because we wanted you to know that, you know, we are using these questions to determine what your 5-year and lifetime risk for breast cancer is. So it's kind of important that you really try to pay attention and fill that out. Once you fill that out once, we are coming into the computer age now, so we do store that data and we just will update it every year after that. If you have a risk that's less than 20%, greater than 20%, MRI is still considered the gold standard, so the recommendation is go ahead and have an MRI. If you're less than 20% and you have dense breast, our suggestion is that you have the molecular breast imaging. And based on that, if it's negative or positive, you may be placed into biopsy or you can go back to screening the next year. I'm sure everybody's heard that about Chuck Norris's wife. Have you heard that in the news lately? So Chuck Norris's wife is suing some of the gadolinium makers because they feel MRI for the breast has to be done with gadolinium. And gadolinium, there's 2 forms of gadolinium. There's what's called a linear agent and a cyclic agent. The linear agents, they feel, may have some problems with deposition, and she apparently had multiple injections of this linear agent, and she has long-term sequela from it. So we don't really know what the complete, gadolinium, it's been out forever, but this is a test that you can do without gadolinium injection. That's the other thing. If you're a woman who has a pacemaker or an aneurysm clip and you're not a candidate for an MRI, MBI is another viable option. So these are just a few little facts. Compared to conventional mammogram, when you have MBI, there's approximately 400% or 4-time increase in the number of incidental cancer detected. So you can look at this. So with the mammo alone, you may find three cancers. When you screen 1,000 patients, with MBI, you add approximately 8 to 9 cancers detected. Ultrasound, which is what we're currently using for dense breast, you add about 3. And you can look at this number for MRI, 14.7, right? So you say, wow, why don't we all get MRI? Well, if you drop down a little bit, look at the false positive rate. The false positive rate for MBI is between 6 and 8%. The false positive rate for MRI is almost 25%. What does that mean? That means 1 out of 4 MRIs that look positive that you're going to wind up getting a biopsy are going to be negative. So just to be told that you're going to need a biopsy, that can be very distressing, and MBI does help in terms of cutting down the number of biopsies that we have to do. And on the opposite side, the positive predictive rate. So if you have a positive MBI, like what are the chances that this is going to be something positive? You can look at this number down here, 33, a third of them to 20%. So a fifth to a third of the MBI positive cases will be positive. What are the ones that are negative? Well, there are certain things that can be negative. We're finding out, because we're really trying to biopsy everybody who has positive MBI, that if you have any kind of chronic inflammation, that those cases can be positive as well, and we can just follow you. We will biopsy. If it's inflammatory, then we know that, if there's inflammation, that goes along with the positive MBI. So I'm going to show you a few cases. This is a MLO breast, and there is a cancer in here. You can see that the tissue is not extremely dense, but it is somewhat dense. It's what we call heterogeneously dense, all right? So we do the MBI, and can you see where the cancer is? I mean, I know it's labeled, but even if it wasn't, I think it's pretty obvious, yes? So this is why it kind of becomes like a no-brainer for us. Here's another case. So this is a screening mammogram, and we saw that there is something here. There's a little increased density as opposed to the rest of the breast. But the thing that's really hard to see is that, so this is the one that everybody knew about. This is the one that's palpable. But if you look just in front of that one, there's another little focus there. So this is an additional cancer that was detected only on the MBI. Here's a few more. So this is a mammogram, and I know it looks dense, and you may say, oh, well, this is so obvious, but it looks kind of like just like everything down here. And the same thing here. This whole breast is basically white, but on the MBI, you can see that at the little like moon-shaped area of increased uptake, and this is a cancer. And same here. There's an area of increased uptake on the molecular breast imaging. So these are both positive biopsy-proven cancers. Right now, one of the issues that we're having is insurance companies don't want to pay for this. Many do, but a lot of insurance companies are telling us that this is experimental. Fortunately, I'm hoping that this is going to change. The American College of Radiology just issued the guidelines for molecular breast imaging, the parameters. So this is good news. It's retroactive as of October 2017. I put the, if you want to see what the guidelines are, there is the link. And thank you very much for having me. If you have any questions, I'm happy to answer them. Getting over a cold.
Doctor, I was wondering if it helps early stage cancers in women who may not have dense breasts.
I'm sorry, I didn't hear you.
I said, is it also helpful in detecting early stage cancers in women who maybe have non-dense breasts?
It can detect cancer in any density of breast because it's independent of density. But in the women who tend to have the fattier breasts, there are other ways that it may be easier to detect them. But certainly it's good for any type of breast because it really is independent of the density.
I'm just wondering what the cost of the test would be if somebody were interested in having it and their insurance doesn't cover it.
All right, so the cost of the study, if you pay out of pocket, is approximately $450, as opposed to an MRI of the breast. If you were to pay out of pocket, I think it's upwards of $1,200. So it's about, it's significantly less.
As a survivor, is this a test that if our insurance companies did not approve, we should fight for so that going forward we could kind of avoid potentially missing something early stage?
That's actually an interesting question. Absolutely, I think you should fight for it. Just this past, I think, 2 weeks, I had a patient who, breast cancer survivor, she had a lumpectomy, and I think she was on year 5, or maybe right on the cusp of year 5, and as you know, we follow you for approximately 5 years. On her mammogram, she actually had a little spot, and we didn't do we actually wound up doing the retrospective, we did the MBI, and the MBI was in fact positive. We tried to find it on the sonogram, but because of the scar tissue that was there, it was really, you couldn't see it on you could not see it on sonogram, but it was, there was like a slight change on the mammo, so we decided to biopsy it on the mammogram because the MBI was also positive, and in fact it was a recurrence. So you can use it for that, absolutely.
I will compare this to At tomosynthesis mammography, I watch the heel, number one. And number two is if you need a core biopsy to be done, can you do it with the MBI machine?
Okay, so the tomosynthesis is a 3D mammography, and again, it's an anatomic imaging modality. So even with tomosynthesis, basically what tomosynthesis does is it creates thin slices through the breast. Rather than kind of like looking at it just as a whole, you're like kind of slicing through it with multiple slices, and then you stack them together and you create the image. It's kind of like a CAT scan. You know, like when you do CTs, you see like slices, right? So it's kind of like that. But even with tomo, we're finding that if you have a dense breast, you have a dense breast. It's still white. So yes, tomo is better, but when you have a dense breast, some of the problems that we had with 2D mammography, we still have with tomo. That's the first thing. The second part of that question, I'm sorry, can you repeat that?
If you see a lesion with the MBI, can you do a core biopsy, or you have to use ultrasound or regular?
Okay, so the MBI, there are blueprints to make the add-on to biopsy with MBI currently, but they haven't actually put it together. Because we do image you in the same planes that we do with the mammogram, it's relatively easy to triangulate the area of interest either on mammo or a sono. So I've actually biopsied the positive findings stereotactically as well as under ultrasound. So currently, no, we'll be able to do it, just not now.
What's the yield for benign breast disease, benign high-risk breast disease versus invasive cancer?
Well, okay, so basically, if
DCIS, ADH, LCIS, the other things that we can pick up on mammogram and MRI, which we often find survivors.
Mm-hmm. Actually, a lot of the cases that we're finding are DCIS. Because we are biopsying anything that looks positive, and we go back to the mammogram, and if there's anything there on the mammogram or the ultrasound, even if the patient has like calcification throughout the entire breast, but in the area that the MBI is positive, we see calcification in that area as well. Because when the whole breast has calcifications, it's really like, what do you biopsy? And you see that the patient has, they'll have like 4 tissue markers there next to calcifications, and then the MBI is positive, then we'll go for the calcifications that are in the area that the MBI was positive. And a lot of times that will come back DCIS often.
Thank you. I'd like to call up to the podium Dr. Thomas Davenport. Dr. Davenport is a partner at Long Island Plastic Surgical Group. He is the Director of Microsurgery and the Director of Surgical Wound Care at NYU Winthrop, where he also holds the appointment of Chief of Plastic Surgery. He has authored numerous articles and book chapters and lectured nationally and internationally on various aspects of plastic surgery. Dr. Davenport will be moderating our panel discussion with his peers on innovations in breast reconstruction. Dr. Davenport.
So good morning, everyone. I am back as moderator of this panel after a couple of years. So in light of this being election day, I would like to thank everyone who voted for me. Yeah, I think in the end it came down to be between me and nobody. And I still hear it was close. So I would just like to thank everyone who voted for me. And I would like to call up those people who will be part of our panel. Dr. Matthew Kilgo, Dr. Harry Douglas, and Dr. Noel Natoli. Okay, Dr. Noel Natoli received her undergraduate degree at the College of William and Mary and obtained her doctorate degree of medicine from Upstate Medical Center in Syracuse. She went on to complete her combined residency in plastic and reconstructive surgery at Penn State Hershey. She then went on to the University of Pennsylvania and Philadelphia for a microsurgical fellowship in plastic and reconstructive surgery. And while at the University of Pennsylvania, she focused on autologous breast reconstruction, and she's also a surgical team member for the Planning and Development Committee of the Hand Transplant Program at Penn. Dr. Kilgo graduated summa cum laude from bachelor's degree in biology from Loyola University of Chicago in 1989, and he later received his MD degree from the University of Chicago Pritzker School of Medicine. He went on to complete a general surgery internship and residency at the University of Wisconsin. After residency, Dr. Kilgo received an additional training with a focus on breast reconstruction and vascular surgery at the Gloucestershire Hospitals in the United Kingdom, where he served as a visiting surgical fellow for 1 year. Following his general surgery training, he completed a plastic surgery residency at Indiana University and an additional year of subspecialty training at Memorial Sloan Kettering Cancer Center. Dr. Douglas is a graduate of Trinity College in Connecticut, where he majored in studio arts and physics. He obtained his medical degree from Bowman Gray School of Medicine of Wake Forest in North Carolina in 1980. He completed his general surgery residency at Mount Sinai Hospital in New York, where he also completed residencies in microvascular surgery and plastic surgery. Dr. Douglas then completed a fellowship in pediatric plastic surgery and maxillofacial surgery at Children's Hospital in Akron with the Northeastern Ohio School of Medicine. So I'm going to move on and start our question period. There will be an opportunity to ask questions at the end. So start thinking of your questions. Remember, this is a competition. I think, Gary Blank, last year we gave away a Mustang convertible, is that correct? So I want you to start thinking of your questions now. Very, very competitive. So we'll start the questioning with Dr. Kilgo. Dr. Kilgo, can you tell us what prepectoral breast construction is?
Sure. So prepectoral breast reconstruction is really one of several types of what we call prosthetic breast reconstruction. That means implant, expander-based reconstruction. I think before we talk about that, it might be helpful to review the development and evolution of prosthetic breast reconstruction in order to put prepectoral reconstruction into the appropriate context. So the more traditional technique, the one we've been doing for many years, is something called subpectoral breast reconstruction, where the expander, which is essentially an inflatable implant, is placed entirely below the chest muscle. And while that provides excellent coverage, it can really limit our ability to expand that pocket up and take advantage of the excess skin left over by the breast surgeons utilizing some of the newer skin sparing and nipple sparing techniques. And without being able to really utilize that tissue, it can compromise the aesthetic outcome. So in order to deal with some of the shortcomings, we began performing something called partial subpectoral breast reconstruction, which involves really dividing a portion of the chest muscle, the pectoralis major muscle, and allowing it to elevate up and replace the expander below the muscle to some degree. So the upper 2/3 to one half of the expander is covered by the muscle, and the lower portion of the expander is covered by something called an ADM, which is short for acellular dermal matrix, which is really a biologic mesh that incorporates fully into the patient's own tissue. And what that technique does is it allows that pocket to really expand, to really incorporate that additional breast skin, and I think it improves the contour and shape of the ultimate breast reconstruction. And in addition, because that space is increased, sometimes we're able to, in the appropriate patient, skip the initial expander stage and just go directly to an implant. So that technique further evolved into what's called prepectoral breast reconstruction, where we're not touching the chest muscle at all. So it's a minimally invasive procedure. The expander is placed over the chest muscle, and we're covering it in its entirety with the ADM. So that really maximally utilizes that excess skin. It creates a more natural looking breast reconstruction. It's got excellent shape and contour.
Dr. Kill, can you just speak a little bit more about what are the advantages of a prepectoral breast reconstruction as compared to what the traditional technique was like?
Sure. So there are really two main advantages. The big one is pain reduction. So you can imagine dividing the muscle, elevating the muscle, doing that dissection. That can increase the degree of discomfort after surgery. So by placing the expander on top of that, and not touching the muscle at all, it really reduces the postoperative discomfort. I think in my experience, patients tend to go home from the hospital a bit earlier, they use less pain medication, and really overall have a quick recovery. And one thing that I think that's underestimated is the expansion process. The expanders are under the muscle and stretch that muscle, and that can be very uncomfortable. With prepectoral expander or implant placement, that's really reduced significantly because you're not having to stretch from the muscle. And the second thing, and equally as important, is something called an animation deformity. So in patients who have subpectoral breast implants, when the chest muscle activates, which happens all the time, the implant can move and the skin over the implant can crease. It's a very unnatural look. It can be very troubling for some patients, and in fact, it can be uncomfortable. So placing the implant above the muscle essentially eliminates that.
Now, this is an exciting development. Obviously, as we've talked about in previous discussions, there's two types of implants, two types of reconstructions. One is the autologous and one is the implant. And there are little benefits to both, and there are issues with both. Are there any patients that are not a candidate for the prepectoral, or is there any patients that this could be difficult or an issue to perform?
Yeah, there are actually. So we put it underneath the muscle for many years for a reason, and that was to provide additional coverage over the implant, and really to prevent a small complication from becoming a big complication. Meaning, if there's wound healing issues, infection in the skin, we don't want that to infect the implant. And with the prepectoral reconstruction, it's only covered by a thin layer of ADM, so those patients don't do quite as well when there's wound healing problems. So in patients who are more apt to have problems with healing wounds after mastectomy, somebody who has very thin flaps, or somebody who's diabetic, active smokers, and concerned about radiation, they're probably best served by a subpectoral or even autologous tissue reconstruction.
Thanks. In terms of breast reconstruction, one of the issues that we've been hearing a lot about in the press, and something that we've seen a lot over the past 12 months, has been an issue called anaplastic large cell lymphoma. And this is something it's been in the lay press quite a bit. And so I'd like to ask Dr. Douglas just a little bit to explain about this issue and whether it's really something that we should be following, and whether this is and how this will impact breast reconstruction and the use of breast implants and reconstruction. So Dr. Douglas, what is breast implant associated anaplastic large cell lymphoma?
So this has been a recent development that is affecting implants, and potentially it is not just reconstruction. When you understand that 65% of breast reconstruction is implant-based, but it is also affecting cosmetic augmentation, which is also using implants. So the Breast Association here is that the ALCL, which stands for anaplastic large cell lymphoma, is a very rare, and I want to emphasize, a very rare association that is now linked to textured, predominantly, almost universally textured implants, predominantly by Allergan, which is now Natrel, but Allergan, McGann, any of those were the same corporate lineage, producing textured implants by what was called a biocell salt loss textured method. The other implant manufacturers have been much less implicated, almost to being negligible. It's a frightening thing when you think about it, but it is very, very rare. The typical timetable for presentation is about 8 years after the implant, either for cosmetic or reconstructive purposes, has been implanted. And again, for the large majority of patients, smooth implants, meaning that the outer wall of the implant is smooth, have not been implicated. It is the textured implant for both cosmetic and reconstruction.
So, Dr. Douglas, you mentioned that this is a very rare phenomenon. How common is it exactly?
So the database has been collecting information for about 7 years now, and there are a couple of hundred cases. The typical presentation is for someone, as I said, having an implant for approximately 8 years. Now, how do they present? Typically, and about 80% of the times it is with a seroma that all of a sudden occurs. So that means that someone that has general symmetry for these years and no problems, all of a sudden they start to get unilateral expansion of the implant. The implant looks larger, the breast looks larger, and then that has to be investigated. So the treatment at that point would be to get a sonogram to confirm the presence of seroma, and then they do a needle aspiration. The needle aspiration is then sent for cytology, it's sent for culture, it's sent for flow cytometry, and for CD30 markers, the receptor protein. And then that is assessed. If it is positive for ALCL, which is a non-Hodgkin's type lymphoma, it is in the T cell line. The treatment, if it is documented, and again, this is very, very rare, the treatment in almost 95% is removal of the implant and a total capsulectomy, meaning that you're taking out the entire fibrous shell that surrounds the implant. And in almost all cases, that is curative. There actually have been a couple cases where they present, in addition to the seroma, they present with the seroma plus a mass, which is a little bit more ominous, meaning that the tissues are growing, the tumor is growing outside of the capsule, and there have been metastasized cases of metastasis, and actually a couple of deaths from the ALCL. But again, the important point here is that this is extremely, extremely rare. When you figure that there's about 35 million implants in circulation throughout the world, they figure that roughly, because there's not that many cases documented, that the overall incidence is about 1 in 300,000 people. And again, this is associated with the textured implants.
So, Dr. Douglas, you had mentioned that this is very, very rare and it happens in textured implants. So, for instance, if a patient has a textured implant, should they ever consider possibly having it exchanged or removed as a concern?
If everything is fine, everything is symmetric, there's no evidence of any sudden changes like a mass or asymmetry suggesting a new seroma, there is no reason to do anything. It is purely surveillance. And people that do have ALCL, the surveillance would be either a CT or PET scan every 6 months for about a 2 to 5 year period of time.
So also, Dr. Douglas, for the new patient who's diagnosed with breast cancer and they've chosen to have an implant reconstruction, are there other options for reconstruction besides the textured implants? And these implants are still being used. Should they be concerned to use the textured implant?
The FDA still thinks that they are a safe device. They have not pulled textured implants out of the marketplace. For the most part, the easiest thing to do is to not use one of these implants using the BioCell salt loss texture, to use some of the other implant manufacturers that have not been implicated with such a high rate, or just use these smooth implants, which in cosmetic is the majority.
Thank you. So one of the things we, being part of this panel and being part of this program, is we always bring up, well, what are the advances and the wonderful things going on in terms of the treatment and diagnosis of breast cancer. And plastic surgeons really have come very far in terms of, even especially over the past 5 to 10 years, of the new options that we're using for breast reconstruction. The results today are outstanding. I remember 20 years ago we were looking at the results and they were good, never expecting the results today would be as good as they are. And even today, as a plastic surgeon, it just amazes me. And Dr. Kilgo talking about prepectoral and nipple sparing, and one of the most exciting things that we have seen is something called fat grafting. And I want to ask Dr. Natoli, this is used a lot now in breast reconstruction, so how can this help or aid in breast reconstruction today?
Fat grafting in general is a process. It's 2 parts. It's liposuction, so unwanted areas of the body we take fat from. It's an added bonus for patients, and then basically we lipofill or perform fat grafting into the area of the breast. And it's different than the prepectoral or implants versus autologous, because it really can be used with either an autologous kind of reconstruction or in lieu of reconstruction or with an implant reconstruction. So it's really revolutionized how we do perform and kind of supplement our breast reconstructions, because a lot of patients who have had complaints with one type or the other of breast reconstruction have areas of contour and areas that they're unhappy with, that you can see the visibility of the edges of the implant, or maybe ridging in their natural reconstruction. And so with fat grafting, we're able to take their own fat, so it is considered a natural reconstruction, and we're able to process that fat. There's some systems that do it. Revolve is one system that Lifestyle has acquired that helps us process the fat and basically then perform the fat grafting. And we've, because we know the techniques better of fat grafting, we can predict the things that we can do to aid and help the fat for better take and enhancement. So if you read online about fat grafting, you'll see the results can be unpredictable, and your doctor may often put a lot more fat in than they expect, because you do expect a certain amount of resorption. But it's really changed how we've practiced in plastic surgery, and it's not often used as a standalone technique. That has been used with a device called Bravo, which helps to expand the pocket ahead of it, but that's off the market right now. So it's really just been a tool that we can add to our armamentarium to help with breast reconstruction.
So any procedure that starts with getting liposuction always seems interesting, but there's always there always seems to be a downside to something that sounds pretty interesting. Are there any downsides to fat grafting? Are there any risks associated with doing fat grafting in a patient who needs it for breast reconstruction?
Sure, so there's always risks to any procedure that we can offer our patients, especially in breast reconstruction. And some of the common risks with fat grafting can be the downsides of the fat not taking. So there can be what we call fat necrosis, where either a piece of fat or a conglomerate of fat cells is kind of clumped together, and because of it, the blood supply to the area isn't as rich, and it doesn't incorporate as well, so it doesn't take as well and become part of the natural and vascularized tissue. And so as a result, if that fat doesn't have a blood supply around it, it can be hard and can sometimes feel like a little mass. It's very easy to distinguish in a patient with implants and even in autologous reconstruction who's had fat grafting where the fat necrosis is. However, if there's any suspicion or if there's any pain in the area, certainly imaging can be used. And we've had good results in terms of imaging this, and radiologists are able to tell the difference between what looks like something concerning on a mammogram and what looks like fat necrosis. But that's certainly a downside. You can get basically drainage or an infected seroma as a result of the fat not taken. So some of the variants of complications that we have with our normal implant or autologous reconstruction can happen with fat grafting. Additionally, with liposuction in general, it has its own risks with the surgery. Certainly there are benefits to it, but patients are sore there. They feel like they've really been beat up and that I've been punching them in the belly or the legs, wherever they have the liposuction taken from. In addition, you can end up with a contour abnormality, so an area that's not perfectly smooth where you take the fat from. And I would say asymmetry may be considered another downside or risk of it if fat takes more readily in one area and not another.
So you had mentioned that it's used as an adjunct to other forms of breast reconstruction. So can you just, from a cosmetic perspective, can you just explain to us exactly how it's used? And also, if there's a patient who's had breast reconstruction maybe 10, 15 years ago, before this was an option, is it still an option today to improve their result the same way you're able to use it to improve results of patients who are having the surgery today?
Yes, it's a good question. So we're not certainly just using fat grafting for reconstructive cases. It's used in aesthetic surgery. A lot of women who want to have breast augmentation without having an implant want something natural, and we're able to fat graft those women. And as I alluded to, the device before, Brava, is a device that is used to pre-expand the chest wall. It may be released back on the market. There are some still in circulation. But basically, by expanding the pocket ahead of time, by putting what looks like an external expander on the chest, we're able to increase the breast, but that alone would only cause a temporary increase in the breast, which almost looks like swelling, and then they subside back down. So with using an expander like this and then putting the fat in conjunction, you can aesthetically increase the size of the breast. You can do that without the Brava device, without an expansion device, but the amount of fat that you get to take, so the amount of an augmentation that you can offer a woman cosmetically would be smaller. And it's also used for enhancement, you know, facial rejuvenation. People are using fat grafting. It's changed our practice in general in plastics. In terms of our, in terms of our reconstructive patients, I'm using it endlessly, I would say, in patients who've had reconstructions in the past that have fine-tuning or tweaking or areas that are bothering them, or patients that have switched now from subpectoral to prepectoral reconstruction and have visible upper poles, or they're thin, or just ridges of the along the implant. And then also in patients with delayed reconstruction, so they've had lumpectomies maybe 10 years ago, they never really wanted to do anything. Now the fact that they just have gained 10 pounds and really can't fit into a bra because their breasts are asymmetric, and it's very hard to work with a radiated breast with a lumpectomy patient. And I think fat grafting has really transformed how we can improve these women's lives, because the fat in general, especially in the setting of radiation, can help to soften those tissues and make the breast appear you know, more youthful and softer in general.
Okay, so now I hope you've been thinking about your questions. I have some, but I would like to give the people who are here who may have questions about their reconstruction or reconstructive options, or some of the things that we've talked about during the panel discussion. So, and again, this is a competition, so we will be keeping track. Please, no wagering, though, from the back. Okay, so who has a question? From the also, don't answer this, but if you were to take a lot of fat out and only use some of it and discard the rest, is that a possible procedure? Just asking. You don't have to answer that.
Hi, it's me again.
Sure.
So a woman is diagnosed with breast cancer, and she doesn't know what she doesn't know, but she hears about reconstruction, and as her stress level increases and her husband or her partner is saying, "It's okay, honey." My friends are looking at me. But you don't know what you don't know, and you have so many other considerations to go through. How does a person find out the questions to ask while still being asked to determine other methods of treatment? Because you don't know what you don't know.
That is an excellent, excellent question. Thank you for asking it. I'm going to put that up as a jump ball to our panel if someone would like to take it up.
Yeah. So I think it is a difficult time, but our job as reconstructive surgeons is to give you all the information that you need. There are many different types of reconstruction. We talked about a few today: implant-based, above and below the muscle, deep flap, the latissimus flap. It's a lot of information. So what I try to do when I see a patient is to give them all the information, and ultimately it's a decision that you need to take into consideration about your lifestyle, about other types of therapies that might be necessary, and to find out what's really right for you. So importantly, I think you need to find a plastic surgeon who offers all those techniques, because not everybody does. And it's important to have all the options open and available to you, because in certain circumstances, someone who, for instance, is going to need radiation does better with a certain type of reconstruction versus somebody who doesn't. So the bottom line is, I think, find a plastic surgeon who's board certified, who specializes in breast reconstruction, and who offers all the available options. Our group, no, but we work with, very closely with the various hospitals, and most of the hospitals, Winthrop, Mercy, have nurse navigators and are able to plug people into programs to help with that.
And I just want to piggyback one thing on that. I would say that for patients that are going through this, it's completely overwhelming, as Dr. Kilgo had said. However, to keep your options open is always important. So for patients that are considering, too overwhelmed to really consider breast reconstruction, we recommend still having that appointment and consultation just so they know what their options are.
Hello. It was mentioned before in the summit about how stage 4 is intreatable, it's terminal in breast cancer patients. Is that true in other cancer-related diseases? Like chemo cannot treat a stage 4 person?
Sure. In tumor description, there's something called staging, and each time we stage a tumor, it's based on parameters that we look at, which will help us affect how to treat that person. So the first thing we do is when someone is diagnosed as an oncologist is it's staged, and then the next thing we do is we use that staging to determine treatment. Depending on which type of cancer, and a lot of the different specifics of that type of cancer.
The type of cancer would be melanoma. Would that's stage 4, is that terminal, or can you treat that with chemo?
There are certain implications of having stage 4 melanoma, and sometimes there are ways that it can be treated which will improve the condition. Obviously, the higher the stage, it affects prognosis. But again, every year they come up with new different treatments that can improve the survival and help the person.
Thank you very much.
Hi, I have one question.
Sure.
Is breast MRI still the method of choice as far as monitoring implants? I mean, because, I work in a breast care specialist, Dr. Kaufman. As far as silicone implant, I still monitor my patients with silicone breast implants every 2 years with breast MRI. Is that a choice, or is that a good method of monitoring implants?
Well, either silicone gel or saline implants are radio opaque. So standard mammography has to be done by skilled technicians that can do tangential views to see them.
With bilateral mastectomy with silicone implant, the way I'm monitoring patients is through breast MRI every 2 years.
That would probably make sense.
That's a good choice of monitoring patients, right?
Absolutely. Yeah. So just to elaborate on that, the FDA at this point, it is certainly the most sensitive test for detecting either intercapsular or extracapsular rupture.
Yeah.
So the FDA at this time recommends an initial MRI 3 years after the surgery.
Correct.
And then every other year after that.
Correct. But most insurances now are not approving breast MRI.
Well, I would say for reconstruction, it's less of a problem than it is for cosmetic breast surgery. That's a real issue.
Yes.
We let our patients know about that before they get cosmetic breast surgeries, because some insurance companies will cover it, some won't. For reconstruction, for the most part, we haven't had any problems with that.
Well, that's one of my problems right now is insurances don't cover because they think that it's not really necessary.
I've had situations where they will refuse an MRI and ask for an ultrasound, which is a much less sensitive test. And if the ultrasound is equivocal, then the patient may authorize an MRI.
One last question. Over here.
I guess I had a couple of things. She touched on one with the silicone versus saline, but if you have a silicone implant, is the length of time before you need surgery again to get it replaced different between the silicone and the saline, since the silicone, I guess, has the risk of, if it leaks, causing a problem. And my other thing was about the fat grafting. On the radiated side, I think the doctor said that she was having good results with that. So for nipple reconstruction on the radiated side, would you suggest the fat grafting versus not doing any nipple construction on the radiated side without it?
So let me just ask you to clarify the question in terms of the fat grafting. You're saying the use of fat grafting with nipple reconstruction?
Well, I have a double mastectomy with the silicone implants, subpectoral, and my plastic surgeon said that she doesn't suggest doing nipple reconstruction on the radiated side. She told me that she had a younger patient that she fat graft and that she sees good results too, that the fat grafting makes she told the girl she couldn't get nipple reconstruction but saw her 6 months later after fat grafting and it was really, really good. She was surprised and she told the girl she could get the nipple reconstruction. So I didn't know if there's like any kind of rule with that on the radiated side.
I see, I didn't understand what you're saying. In terms of the exchange of implants, as we had stated, the FDA recommends initially implants be, you have an MRI at 3 years and then survey every other year. In terms of what they recommend, that these implantable devices, and again, we're getting, grandma's implants are not the implants we're putting in today. We're putting in 4th and 5th generation implants, and as a result, the older implants with the saline implants, when they rupture, you would know, and you still know because they deflate like a tire, whereas the silicone implants and the gummy implants that are more cohesive these days, it's kind of like more like a jello mold or a gummy bear, and so if they rupture, most of the time it stays in the capsule and they kind of shake like a jello mold, but it doesn't really go anywhere, so they're much less risk. I mean, I'm still taking out implants that are older than me because women had implants 40-something years ago and they make a mess and they spilt everywhere like honey, but those aren't on the market anymore. But the FDA still does recommend that devices be exchanged at 10 years. However, if you come in to see your plastic surgeon at your 10-year follow-up and everything looks great and you're happy, if you're due that year for a surveying imaging study, you have that done, then there's no reason to not put it off. I usually try to plan with my patients in terms of their age. If I have a 50-something-year-old woman, I say you're probably going to need 1 implant exchange, and then you can take those with you to, the next life. However, some patients say, it's 10 years I need to, and they have an itch to do it, and that's fine. The secondary surgery to have implants exchanged is usually quite quick. To answer your question about fat grafting, yes, fat grafting can often bridge radiated patients to basically, I've had patients in your exact situation where they had radiation. It was a very thin mastectomy flap, and I was just too nervous to offer the patient nipple reconstruction. And I was actually even nervous to offer her tattooing or 3D tattooing because I felt like there was a couple of cell layers between her skin and the implant. So fat grafting can be a bridge. You do basically multiple stage surgery where you put the fat in first to help soften things and add that extra layer, and then possibly do nipple reconstruction at a later date. And I'm really having a lot of tremendous luck with 3D nipple reconstruction and just advances in tattooing that basically, if you guys are familiar, it's basically tattooing to make the nipple look like it has projection. And so a lot of women are bothered by nipple reconstruction because they like their perky implants and they like not having to wear a bra. And then you do their nipple reconstruction and suddenly things look like they're erect all the time and they look like they're cold and they don't like that anymore. So a lot of patients of mine had opted out of having nipple reconstructions so that they could do 3D tattooing for nipple reconstruction. So they're both options, and I think that fat grafting is often used in conjunction with nipple reconstruction.
So I would like to thank our panel for giving us this great information. And I would also like to thank everyone for their great questions. Thank you so much, and we're going to move on to the next part of our program. Also, by the way, we're going to be tallying up the results, and you'll be notified of the winner sometime in the next 12 months. Thank you.
Always the jokester, he is. But thank you, doctors. That was very informative. Again, if we weren't able to answer your questions, you can write them down on the card. Just in the interest of time, we're going to move along with the program. At this time, I'd like to introduce Dr. David Kreiner, manager and co-founder of Long Island IVF. Dr. Kreiner started his reproductive medicine training in 1980 with Dr. Zev Rosenwax for a few short years after the world's first IVF baby was born. He graduated cum laude from SUNY Downstate Medical Center, College of Medicine in 1981, where he was elected to the AOA, the Honor Medical Society. Dr. Kreiner continued his training in REI from 1985 to 1988, when he did his fellowship at the Howard and Georgiana Jones Institute. Those are the pioneers of IVF in the United States. In 1988, he established Long Island IVF. It was here that he produced the first successful births through in vitro fertilization on Long Island. Dr. Kreiner, please.
Thank you. I think my mother wrote that. So we're going to talk about fertility preservation and breast cancer, which is becoming really a very interesting topic and very important today, as the rates of survivorship have improved enough so that we need to spend time considering the quality of life after cancer. And for many patients, this high quality of life includes the ability to have children. Now, how does cancer affect fertility? In large part, it's caused by the delay in our ability to reproduce. We have to delay childbearing for treatment, whether it be chemotherapy and/or surgery. And as a result, our patients are older, and age is a very important factor for fertility. What happens as you get older is we have reduced number of eggs, reduced quality of the eggs, and increased percentage of eggs that are chromosomally abnormal. So what we need for fertility is a sufficient number of eggs of good, healthy quality, and also the chemotherapy that we're using has a cytotoxic effect such that it also can reduce the number of eggs and affect the quality of the eggs. And this effect on the ovarian reserve is sometimes permanent and sometimes temporary. And that some chemotherapeutic agents are more likely to be damaging than others. I had the experience of following patients with ovarian failure after chemotherapy many years ago, and these patients were getting ready to undergo donor egg and IVF. But in fact, during the time that I was treating them with estrogen therapy, getting them ready, getting their endometrium ready, in fact, some of them ovulated, and we even had a couple of pregnancies. So it is a temporary condition for some patients. When I see a patient with the possibility of preserving their eggs, I am going to assess their health. I'll discuss the issues with them, and assuming that they want to go forward, it's very important that we know what their odds are. And that is not just a factor of age, which I mentioned, but also their ovarian reserve. That is, how many follicles, how many eggs do they have in their ovaries. I need to find out for these patients what the planned treatment is. How much time do we have before they have to initiate the treatment and for us to perform our IVF and egg retrieval. As I mentioned, the ovarian reserve decreases with age, and therefore the damaging effect of the chemotherapy is not just dependent on the agent that is used, but it's also worse in older patients with less ovarian reserve. So in discussing this with the patients, I'm evaluating the ovarian reserve, and I will go over with them what the odds are given their specific set of circumstances, how old they are, what their ovarian condition is like, and so on. I assess ovarian reserve with three different methods. I'll do an ultrasound examination. This is performed transvaginally, focusing on the ovaries and looking at the number of follicles in the ovaries, so that we actually count these follicles that we can see, and that's a fairly constant number from month to month for each patient. So for instance, if a patient has more than 8 or 9 follicles combined with both ovaries, we know that the ovarian reserve is pretty reasonable. On the other hand, if they have fewer than that, especially if it's less than 6, then we're much more concerned that there's diminished ovarian reserve. We could also measure a hormone called anti-Müllerian hormone, which is produced by the cells in the follicle called the granulosa cells. And as we have diminishing number of follicles, we have a decreased number of these granulosa cells that are producing the anti-Müllerian hormone. So this hormone level will be very proportional to the ovarian reserve for the patient. And then finally, if we have time, we can measure a day 3 estradiol and FSH on the patient. There's a protein produced by these granulosa cells in the follicles called inhibin that will reduce the FSH level. So if the FSH level is too high, then we know that there's also diminished ovarian reserve. It's very important that we discuss the planned treatment with the oncologist and the breast surgeons, get an idea of whether or not there's an estrogen-sensitive tumor, and this will affect the hormonal treatment that we'll utilize. There's a medication, tamoxifen, which you may have heard of, which has been used to treat breast cancer, and in fact, in combination with the gonadotropin hormones, FSH, LH, that normally stimulate the ovaries every month, we can utilize the tamoxifen to actually stimulate ovarian follicles to mature in preparation for IVF. So we are having a consultation with the oncologist, with the surgeon. We're finding out how much time do we have. Are we able to wait for the patient to have another menses, or do we need to start treatment right away? Now, on Long Island, we're very fortunate. We have IVF programs that egg freezing and embryo freezing are standard forms of treatment for us. Ovarian tissue harvesting and reimplantation is still utilized in a few programs. There's actually one, I think, in Westchester that's doing this. But because egg freezing has become so successful, there hasn't been much of a push to spread that technology. So IVF, we wouldn't be here talking about fertility preservation if not for IVF. And in fact, we're celebrating 40 years from the first successful in vitro fertilization that was performed in Great Britain. That baby was born in August of 1978. So it's been 40 years that this technology has been around. In the mid-1980s, we started to develop embryo cryopreservation at the Jones Institute in Norfolk, and that's been very standard form of treatment for 30 years now. And egg freezing has been becoming increasingly successful in the past 10 years, and it's quite standard therapy in most IVF programs. So we're talking about IVF, which includes stimulating the ovaries to get multiple eggs to mature and develop. We stimulate the follicles, the ovarian follicles, with the same hormones that will induce ovulation every month, follicle-stimulating hormone and luteinizing hormone. These are pituitary hormones, but we use supraovulatory doses, higher doses than your body would normally make. So instead of producing the one egg that you would normally ovulate every month, we can induce multiple eggs to ovulate and thereby recruit the multiple eggs, increasing the chances of success. We will stimulate for somewhere between 10 and 14 days, monitoring very carefully with blood tests, hormone levels, and ultrasound examinations. Then perform an egg retrieval. It takes about 15 minutes. It's a needle aspiration through the vagina under anesthesia. And we fertilize the eggs when we do the in vitro fertilization, or in a case where we're doing fertility preservation, the eggs are frozen in that mature state until we are ready to fertilize them at a future date. and then ultimately embryo transfer is performed under ultrasound guidance transvaginally. I'll show you a picture of that later. So these are hormone injections. The FSH and LH hormones are administered subcutaneously. Most of our patients will use a needle that is injected subcutaneously under the umbilicus, under the navel, in much the same way as a diabetic patient would inject insulin. And we do the gonadotropin injections for, as I say, 10 to 14 days, and then the final stage of maturation is achieved with a hormone, human chorionic gonadotropin, which is a surrogate for luteinizing hormone, as it has the same bioactivity as LH. I mentioned we use letrozole. Letrozole, or Femara, is a non-steroidal aromatase inhibitor that actually lowers the estrogen production. It's used in breast cancer in postmenopausal women, and actually we can use it in conjunction with the gonadotropins to get good stimulation of the ovaries. And this is a picture of an ovary that's been stimulated. The follicles are the black circles, and we expect it to be able to retrieve an egg from each one of those follicles. In those cases where we do not have time to wait for a patient to have her menses, as our standard is to start stimulation at the beginning of a menstrual cycle, it was learned in the past few years that we can achieve very reasonable egg maturation, get good mature eggs that can be fertilized and result in pregnancies when we start the stimulation anytime in the cycle. So today we know that we're not limited to waiting for the next menstrual cycle to start a stimulation. We can actually start an IVF stimulation on an emergency basis immediately, regardless of time in the cycle. This picture shows how we retrieve the eggs. We use a transvaginal ultrasound probe with a needle guide that's attached to it, and the ultrasound machine that we use knows, based on the angle of that guide, where the needle is going, so we can line up our probe to the follicle that we're going to aspirate, and then just insert the needle, which is also visualized on the ultrasound guidance, so that we see where the needle is at all times. And this apparatus is attached to a suction machine, so that once we see that we're inside the follicle, we can aspirate the follicular fluid and then hand it over to the embryologist to identify. And we do this in an OR setting. You see the OR table. That's my daughter. So we have the OR table. I'm sitting in the section where patient's legs are up, and to my right would be the ultrasound machine. This is where the embryologist would sit. So there's a window that connects the OR to the laboratory, and the follicular fluid that's aspirated is handed immediately over to the embryologist to immediately identify the egg. And here's the embryologist looking through the microscope, sifting through the follicular fluids until she finds the mature egg. The big circle is the egg itself, and all those little round circles surrounding, radiating around the egg are the granulosa cells that I was referring to earlier. So this forms a crown around the egg called the corona radiata. And once we have decided that we're going to fertilize the eggs, which in the case where there's a partner involved, we might do that immediately that day that the egg is retrieved, or in the case of preserving the eggs themselves, once the patient is ready to go through an embryo transfer, at that point we'll thaw the eggs and perform an intracytoplasmic sperm injection. And you can see that we're utilizing an apparatus where he can manipulate microscopically a needle going into the egg, and I'll show you in just a second. This is showing the needle, which is, you can't see the end of that, it's so small. He's picked up an individual sperm, and now under the microscope you can visualize himself piercing the egg with the needle and then injecting the sperm directly into the egg. And 2 days later, 3 days later, we'll develop an embryo that's now approximately 8 cells, and this is what it looks like. And if we were going to do an embryo transfer, we do that under ultrasound guidance. You can see a white line in the uterine cavity, which is the catheter depositing the embryo directly into the uterine cavity. Today, we also can offer pre-implantation genetic diagnosis. We do this in the blastocyst stage, which is usually about 5 to 6 days after insemination of the egg. We can do chromosome analysis so that we can tell with 97% accuracy whether the embryo is chromosomally competent, whether it's normal. We can also test for some genetic markers that might be associated with cancer, with breast cancer, and thereby decrease the risk of passing on a genetic inheritance of breast cancer. Now, success with egg freezing does decrease as you get older. This study or review performed by NYU showed that the number of eggs, number of mature eggs that it took to achieve one baby in women who were under 35 was 8. For women who are 35 to 37, it took 10 eggs. 38 to 40, 14, and 41 to 42 was 50. And the reason for that is, as one gets older, there's a problem with fewer eggs are chromosomally normal, and even if they're normal, they're less likely to be healthy. So these are my mentors, Howard and Georgiana Jones. I remember when I interviewed for a fellowship position with them in 1984, they spoke about the potential of freezing eggs, freezing embryos for the purpose of preserving fertility for people with cancer. And today I feel like I'm living their vision and dream by offering fertility preservation to women with breast cancer. I want to thank you for your attention. And if there are any questions. Someone in the far corner, huh?
Sorry. You had mentioned that you do BRCA testing. I'm just curious, I am BRCA positive. I'm 3rd generation that I have cancer. I have 2 young girls. I'm just curious to know, I mean, they're not at the age to be tested, but should they be positive down the road? Is there a way to remove the BRCA gene so that they don't pass it on to their children?
Today we can test embryos before they're transferred. We can test in pregnancy. But I think maybe by the time your daughters are old enough, there may be a way to remove the gene, but that's not available today.
Does genetically testing the embryos affect their quality and ability to implant?
No. The question was, does performing pre-implantation genetic diagnosis, testing of the embryo, affect the ability of the embryo to implant? And now that we are performing the biopsy on blastocysts, we're removing the cells on the outer surface of the embryo, which is actually not part of the inner cell mass, doesn't become the fetus. So there doesn't appear to be any effect on the future pregnancy potential of those embryos. The only way in which that may be the case is if, in order to test the embryos, you need to go through several cycles of thawing and refreezing of the embryos, and then you have the extra step. But other than that, there really doesn't seem to be any effect on implantation rate. I think that's it. Well, thank you very much.
Next up, we have our guest of honor and keynote speaker, Alan Rose. Alan is a 29-year-old law student currently living abroad in Frankfurt, Germany. By the age of 16, Alan had lost her mother, grandmother, and great aunt to breast cancer, motivating her to explore her family health history and take charge in her health care. As a successful model, Miss USA and Miss America contestant, she made headlines across the globe with her decision to undergo a double mastectomy at the age of 26, despite being cancer and BRCA1 and 2 mutation negative. By 26, Alan had completed her mastectomy and reconstruction and has continued championing preventative health care. She has been featured on Good Morning America, Fox and Friends, E! News, The Today Show, Katie Couric, Inside Edition, People Magazine, Us Weekly, Cosmopolitan, In Touch Weekly, and was a Fox Power Player of the Week. Alan gave a TEDx talk at Chapman University and continues to work as an advocate and contributor on several national media outlets, sharing a message of hope and the importance of putting life before vanity. We are so happy to have her here with us today. After her talk, she'll be happy to answer anyone's questions. Please welcome Alan Rose.
Well, I just want to thank you all so much for having me here today, and for the Long Island Plastic Surgical Group for inviting me here to speak to share my story. I know that in the past this event has pulled some pretty big names. We've had Fran Drescher, Cynthia Nixon, so if you all are wondering what I am doing here today and why I'm speaking with you all, I can give you a little bit of a background. Let's just say breasts are pretty important to me. Over the last 7 years, I've worked as a full-time model, and I was also a pageant contestant. I competed in the Miss USA and Miss America pageants. So for a while there, I was making my living with my body, and I like to say cashing in on the boobs. And a few years ago, I was asked to give a TED Talk. And when you prepare for something like that, they say, you don't have to be the foremost expert in your topic, but you gotta be an expert. So I went ahead and labeled myself a breast expert.